Welcome. This is a 20-minute talk on the adrenal gland and some of the common pathologies, including their investigations and management. So the adrenal gland. The adrenal gland is a small triangular-shaped gland located on the top of both of the kidneys. The adrenal glands are made up of two parts, so the cortex and the medulla. So our adrenal cortex, this is the outer region of our adrenal gland. It's the largest part and is then subdivided into three further parts. Each of these zones is responsible for producing specific hormones. The adrenal medulla, so that's the area inside the cortex, and it produces adrenaline. So our hormones of the adrenal gland. So we've got our cortex, which produces mineralocorticoids, including aldosterone, produces glucocorticoids, including cortisol, and various androgens. Our medulla produces catecholamines, including our adrenaline. So now we will look at cortisol in further detail. So ACTH from our pituitary triggers the release of cortisol from the adrenal cortex. This diagram just shows this loop. So ACTH from the pituitary triggers our cortisol release from the adrenals. Once cortisol levels increase, we then get a negative feedback loop, which then decreases the amount of ACTH produced in the pituitary gland. We get this release triggered in the morning and in times of stress. During these times, increased cortisol level leads to increased gluconeogenesis, so the synthesis of new glucose, increased proteolysis, so breakdown of our proteins, increased lipolysis, so breakdown of our fats, and cortisol is linked with control of blood pressure. Cushing's syndrome. So Cushing's syndrome is one of our disorders of cortisol. It is when we have too much cortisol produced. Our signs of this is demonstrated from the diagram. We have truncal obesity, so our fat is redistributed around the centre of our body. We get gynecomastia, striae, osteoporosis, hypertension, edema, hirsutism, acne, hyperpigmentation. So when a patient has quite a few of these, we say they have a Cushingoid appearance. Once we've decided that they have Cushing's or a derivative of Cushing's, we then move on to exogenous or endogenous. So we need to decide, is the cortisol coming from inside the body, so endogenous, or factors outside the body, so exogenous. So we go into further detail about the exogenous or iatrogenic causes of Cushing's syndrome. So this is our most common cause of Cushing's syndrome. It is due to increased steroid use, usually in chronic conditions such as asthma or rheumatoid arthritis. If we believe our patient has Cushing's syndrome related to their steroid use, we will look at gradually reducing and then eventually discontinuing steroids. We'll try and reduce their dose of steroids if we're unable to fully discontinue, or we might convert to an alternate day routine. We need to be concerned with these patients because they have a negative feedback loop in place. So the high amount of exogenous steroids have meant the body is no longer producing their own or producing very little. Therefore, abruptly stopping exogenous steroids will then cause adrenal insufficiency and can be life-threatening. Now moving on to a slightly more complicated side of endogenous hormones. So, Cushing's disease, so this is when we have a pituitary tumour, is responsible for 70% of endogenous Cushing's syndrome. The cause may also be adrenal in origin, so our adrenal adenomas or adrenal carcinomas. Or it could be ectopic, so from small cell lung cancers. So how do we investigate high cortisol? Step 1 is to identify the condition. So find somebody who has these Cushingoid features. We then need to decide whether or not their cortisol is in fact high. So we'll start with an overnight dexamethasone suppression test. So a normal response would be a decreased cortisol spike in the morning. Patients with Cushing's syndrome do not have this suppression in the morning and continue to have a morning spike. We can also check 24-hour urinary free cortisol, which again is raised in Cushing's syndrome. So once we've identified that this patient has Cushing's syndrome, we then need to localise where this is from. So we need to test our ACTH levels. Are they raised or are they decreased? Because this can help locate whether this is from the pituitary or from the adrenals. So if we have an adrenal cause, we would then have decreased ACTH due to our negative feedback loop. If ACTH level is raised, this either suggests that the pituitary is overactive and is continuing to pump out ACTH, or we have an ectopic source of ACTH. So although there may be a negative feedback loop lowering the ACTH coming to the pituitary, we are getting this external source. Once we've done this, we can look at high-dose dexamethasone suppression test. This will decrease cortisol in pituitary causes because that tissue is responsive to high cortisol levels. Cortisol levels will be unaffected in a high-dose dexamethasone suppression test, whether there is an adrenal or ectopic cause. Step 3 is combine these two tests together. So if we have high ACTH and cortisol is suppressed in a high-dose dexamethasone suppression test, we'll be thinking a pituitary cause. So then what we need to do is to do an MRI to identify this tumour. If there's no obvious tumour on the MRI, we will do petrosal samples, where we take a sample of the blood from near the pituitary and check whether that is the source of the high ACTH. If ACTH is high, but cortisol is not suppressed during the high-dose dexamethasone test, we need to be thinking ectopic. So what we do is we do a chest x-ray to investigate for lung cancer. If we in fact had low ACTH and cortisol is not suppressed in the high-dose dexamethasone test, we need to be thinking, is this an adrenal cause? Therefore, we do a CT scan of the adrenal glands. So, we've covered causes of Cushing's and also investigations to help localise. So now we need to look at management. So if we have our Cushing's disease, so that was our pituitary tumour, so that was our increased ACTH, suppression on the dexamethasone suppression test, plus a positive MRI or our petrosal samples, therefore confirming a pituitary tumour, the patient will undergo surgery. If it's an ectopic cause, so we have a raised ACTH but no suppression and positive chest x-ray findings, we'll treat our origin, therefore we need to treat for the small cell lung cancer. If it's an adrenal adenoma, so that was our decreased ACTH and no cortisol suppression with the dexamethasone test, plus a node found on the CT scan, we would then do an adrenalectomy or potential radiotherapy. So now we move on to aldosterone. So aldosterone is involved in sodium and potassium maintenance and with controlling blood pressure. It is tightly linked with renin, so renin controls aldosterone production. Renin is produced by the kidneys, which activates angiotensin and stimulates the production of aldosterone. Aldosterone is produced by the adrenals, leading to the retention of sodium and elimination of potassium by the kidneys. So we have our low BP or low sodium, which triggers renin production, which leads to the angiotensin conversion, which then causes constriction of blood vessels, which then causes production of the aldosterone, which then leads to retention of sodium and water and loss of our potassium. This then increases the BP and increases our sodium, which is then corrected the low BP and sodium, which triggered the cascade. So now we can look at disorders of aldosterone. So we start with primary hyperaldosteronism. So our causes are bilateral idiopathic adrenal hyperplasia, so this is 70% of our primary hyperaldosteronism, or potentially an adrenal adenoma, this is known as Conn syndrome. It's important to differentiate between these two as this helps to determine treatment. So, our features. If we look again at the physiology of what's happening, our patients end up being hypertensive, hypokalemic, and alkalotic. So what makes us consider this in our patients? So if again, as we find our low potassium on bloods, there's high blood pressure before the age of 30, or hypertension that's not responding to 3 or more medications. So how do we investigate this? So we start with looking at our plasma aldosterone-renin ratio. If there's a high ratio, therefore high aldosterone along with low renin levels, we are concerned that this is in keeping with primary hyperaldosteronism. If this is the case, we'll then move on to high-resolution CT of the abdomen. If we haven't managed to find an obvious tumour on the CT, or we've found bilateral abnormalities, we'll do adrenal vein sampling to help differentiate between unilateral or bilateral causes. So our unilateral high aldosterone levels, that would be our adrenal adenoma, and our bilateral cause would be our bilateral hyperplasia. Then we move on to our management. So if we have our adrenal adenoma, we do surgery to take it out. If it's bilateral adrenal hyperplasia, we then look at aldosterone antagonists, so spironolactone. And in both cases, we're looking at low salt diets. So we've covered overactive adrenals and the complications that occur when there's too much of the hormones. We'll now look into adrenal insufficiency. So our causes of adrenal insufficiency. So we have our primary causes, so that's adrenal conditions. So we've got primary adrenal insufficiency, so that's like Addison's, that's 80% of our causes. There's congenital adrenal hyperplasia, there's aldosterone synthase deficiency. And in these situations, we end up having high ACTH because our body is trying to increase the cortisol. In our secondary causes, this tends to be our external causes, so things outside of the adrenals. So our pituitary problems, hypothalamic problems, or maybe tumour suppressing ACTH. Okay? So in this case, we get low ACTH. So now we move on to Addison's disease. So this is our most common cause of primary adrenal insufficiency. So in this condition, we get low cortisol, low aldosterone. This is usually an autoimmune disruption of the adrenal glands. So secondary to the low cortisol and low aldosterone, we get several features. So our lethargy, weakness, anorexia, nausea, vomiting, weight loss, salt craving, constipation. We get hyperpigmentation, vitiligo, loss of pubic hair, hypotension. We also get retained calcium, low glucose, high potassium and low sodium. This is our opposite of our primary hyperaldosteronism. These can present after infection, surgery, or trauma. So how do we investigate Addison's? So the main thing we do is a short synaxin test. So we start by measuring cortisol, and we'll find that the level is low. We'll then give a dose of ACTH and measure the cortisol again. Normal function, there should be an increase in cortisol. However, Addison's do not get this response and the cortisol levels remain low. We can also do tests for adrenal autoantibodies. We can look at chest x-rays and abdo x-rays to look for potential infections that cause this, such as TB. We can then get a CT scan of the adrenals to figure out if there is any sort of physical abnormality with them. And if actually we're not sure whether this is from the adrenal cause itself or whether it's a pituitary cause, we might be getting IMRI. So how do we treat this? Really important part of Addison's is patient education, getting them to understand their condition and things to look out for. We can give alert bracelet, so if a patient is found collapsed on the street, they have an alert bracelet that indicates to passers-by that they have Addison's. We will then treat with exogenous glucocorticoids and mineralocorticoids because the body isn't producing enough of their own. So we're looking at hydrocortisone and fluticortisones. Sick day rules are extremely important. So when our patients are unwell, they need to increase their steroid use in response to this. And each patient should have their individual sick day plan. So then we come on to Addison's crisis or Addisonian crises. So patients present with collapse, shock, pyrexia. This can be caused when the body is under stress, so through sepsis, surgery, whether there's adrenal damage, or whether we've withdrawn steroids completely, or whether they've not followed their sick day rules. Our body in this state of crisis requires more and more steroids to maintain normal function. However, this patient, due to poor adrenal function, isn't able to compensate for this and therefore goes into crisis. The way we manage this crisis is we give them IV steroids, which we continue until our patient is stable. So now we'll move on to a few cases to try and apply this knowledge that we already have. Okay? So case 1. With a 28-year-old man who has a blood pressure reading of 175/90. We're concerned that this is a high blood pressure in somebody under the age of 30 years old. So our next step, we need to confirm this blood pressure is accurate, so we'll do ambulatory blood pressure monitoring. This comes back showing a consistently raised blood pressure. We do bloods on our man. All it shows is low potassium. He's otherwise quite well, no obesity, no edema, no acne. So what are our thoughts here? Is this a primary hyperaldosteronism due to bilateral hyperplasia? Is it a Conn's syndrome? Or are we thinking actually this could be Cushing's? So our next step. So we investigate. So we do a cortisol level. So whether this is overnight cortisol or whether this is urinary free cortisol, and we found his level is normal. Therefore, this is not Cushing's. But it could still be hyperaldosteronism. So then, as we've discussed earlier, we do our plasma aldosterone-renin ratio, which shows a raised ratio, and this is still consistent with hyperaldosteronism. So our next steps. So our next step, as we discussed earlier, was high-resolution CT to detect our tumour. Unfortunately, in our man, we were unable to find a tumour. So our next step is to do adrenal vein sampling. Adrenal vein sampling, as we said, decides or demonstrates whether or not it's a unilateral or bilateral cause. In our man, we found bilateral raised aldosterone. So this is consistent with bilateral hyperplasia. So our treatment is aldosterone antagonists, for example, spironolactone, and our low salt diet. Case 2. So case 2 is a different 28-year-old man with hypertension. Again, we're concerned high blood pressure in someone under the age of 30. We then examine our man. He's found to have central obesity, gynecomastia, acne, hyperpigmentation, and he's complained of some headaches. So we're concerned actually that he's had some features that are in keeping with Cushing's. We then do some blood tests. Bloods are showing normal FBC, normal LFTs, however again a low potassium. His HbA1c and fasting glucose are normal. We decided to test his cortisol. So whether we'd have done the overnight dex or urinary free, we found a high level of cortisol. So what are our thoughts here? We're thinking this could be Cushing's syndrome. So we've had an indication to check for Cushing's, so our high blood pressure in somebody under the age of 30. Our examination has been concerning for Cushing's, and our bloods and further testing is consistent with a Cushingoid picture. Our results are in keeping with a Cushing's syndrome, so now we need to localise the source of our cortisol. We need to look at whether it's pituitary, adrenal, ectopic or iatrogenic in origin. Our patient has no significant past medical history, so there are no exogenous steroids in use, therefore we need to look at endogenous causes. First thing we need to do is test our ACTH levels. In our patient they are found to be high, therefore we're considering whether this is pituitary or ectopic. We move on to a high-dose dexamethasone suppression test. Our man has decreased cortisol in response to this test, so our high ACTH levels plus suppression with a high-dose dexamethasone is in keeping with the pituitary tumour. So now what? So now we need to image, so we need to do an MRI. Our MRI does not show any obvious pituitary tumour. Therefore, we need to move on to our inferior petrosal sinus sampling. This compares our ACTH levels around the pituitary and compares it to a peripheral sample. Our patient has higher ACTH levels at the petrosal sample than in peripheral blood. This therefore confirms our Cushing's disease, which is our pituitary adenoma. We manage this through surgery. So what we've covered briefly is the function of the adrenal glands, basic principles behind some of the common adrenal abnormalities, including their investigations and management, so our Cushing's, primary hyperaldosteronism and Addison's, and we've applied this knowledge in 2 case studies. Thank you very much.